Dear students, I am Professor Dr. Reda Saad, Professor of General Surgery in Shams University in Upper GIT unit. We will discuss the esophagus, and first of all, we will start the surgical anatomy of the esophagus. By the end of this lecture, you should be able to describe the surgical anatomy of the esophagus, to identify the important structures related to the esophagus, and correlate it to different clinical presentation and complication. To identify the anatomical and structural difference between the esophagus and other GIT organs, including the blood supply and lymphatic drainage, and to apply this gained knowledge on clinical virtual cases. The esophagus is a muscular tube about 25 cm long. It extends from the hypopharynx to the stomach. It lies posterior to the trachea and the heart in the chest, and it passes through the mediastinum through the esophageal hiatus to the abdominal cavity. We divide the esophagus into three parts: cervical parts, thoracic parts, and the abdominal part or segment. The cervical part is about 5 to 7 cm long. It starts from C6 and ends in T1, T2. It passes between the vertebrae posteriorly and the trachea anteriorly. Lateral to it, we find the carotid sheath and thyroid lobes. We have one important structure here. This is the recurrent laryngeal nerve, which lies in the groove between the esophagus and the trachea. The thoracic part is about 20 cm long. Just above the trachea bifurcation, it passes to the right of the aorta. Posteriorly, we find the vertebrae. The thoracic duct, which is an important structure related to the esophagus in the chest, it lies posterior to the esophagus between the descending aorta in the left and the azygous vein in the right. It passes to the abdomen, passing posteriorly through the right crus, but it doesn't pass with the esophagus in the esophageal hiatus. It passes to the abdomen through the esophagus passes to the abdomen through the esophageal hiatus at the level of T10 with the two vagi. The abdominal segment of the esophagus is short, about 3 to 4 cm, passing from the chest through the esophageal hiatus. It is surrounded by the phrenoesophageal ligament, an important ligament, very important in keeping the gastroesophageal reflux barrier. As we said before, the esophageal hiatus lies at the level of T10. We have three sites of external compression of the esophagus. It is not true narrowing, but just compression from outside. The first site is at the beginning of the esophagus, junction between the esophagus and the hypopharynx. It is the narrowest part, about 1.5 cm. The second compression is from the aortic arch and left main bronchus, and the lumen in this area is about 1.6 cm. And last compression is at its passage through the diaphragmatic hiatus or esophageal hiatus and the lower esophageal segment. It is about 1.9 cm. And of course, these are the sites where the foreign body become impacted, causing obstruction of the esophageal lumen. Histologically, the esophagus is composed of three layers: mucosa, submucosa, and muscularis propria. Very important here that the esophagus is devoid of serosa, and we will see later its application and importance while doing cervical or any esophageal anastomosis. The first layer, the mucosa, we have the stratified squamous epithelium, lamina propria, and muscularis mucosa. And the submucosa and the muscle layer is composed of upper third skeletal muscle, and the lower two-thirds is smooth muscle. The esophagus contains two sphincters, one at its upper end and one at its lower end. The upper esophageal sphincter is composed of the cricopharyngeus muscle, and it is always in a state of tonic contraction at rest and becomes relaxed one at the start of the pharyngeal phase of swallowing. The lower esophageal sphincter, it is a physiological sphincter, not a true anatomical sphincter, having a pressure from 15 to 25 millimeter mercury. This pressure becomes very high, more than 40 in one pathological condition called achalasia, and become very low in gastroesophageal reflux disease and scleroderma, usually below 10. Below the diaphragm is always the position of the lower esophageal sphincter. If we found this lower esophageal sphincter lying above the diaphragm, this is pathognomonic of what is called sliding hiatus hernia. Being a muscular tube, so it has peristaltic activity, and for the esophagus we have three types of peristalsis: the primary, secondary, and tertiary. The primary peristalsis is due to entering of food bolus into the esophagus. The secondary peristalsis is due to local distension of the esophageal wall by the residual bolus, and the tertiary peristalsis is a pathological and non-propulsive force, and usually it is in a retrograde direction. To study this motility of the esophagus, we have a device, what is called manometry. It serves to record this peristalsis and the pressure in the upper esophageal sphincter and lower esophageal sphincter, as well as the contractility of the esophageal body. Its importance lies in the diagnosis and before operation of some of the pathological conditions of the esophagus, like gastroesophageal reflux disease and achalasia. The vascular supply of the esophagus, the arterial supply is segmental. The lower esophageal veins drain into the left gastric veins, and it is very important when it becomes dilated in cases of portal hypertension and leads to what is called esophageal varices, which is one of the important sources of upper GIT bleeding. Concerning the arterial supply, we have the cervical part gaining its blood supply from the inferior thyroid artery, the thoracic part of the esophagus gaining its blood supply from the tracheobronchial arteries, and the lower abdominal segment gaining its blood supply from the left gastric artery. The nerve supply of the esophagus is mainly parasympathetic through the two vagi, because we know that the esophagus, as we said, the lower two-thirds musculature is smooth muscle. We have what is called Meissner plexus and the myenteric or Bach plexus, responsible for peristalsis. The left vagus lies anterior to the lower esophagus, while the right vagus lies posterior. And care should be taken during the section of the esophageal hiatus to keep this vagi in case of hiatal hernia repair. The lymphatic drainage is very important for cases of malignancy. One single submucosal lymphatic plexus all through the esophagus. This is the very peculiarity for the esophagus. And this submucosal lymphatic plexus goes up and down. For the upper third, lymphatic pass upward to the deep cervical lymph node. For the middle third, it passes to mediastinal lymph node. And for the lower third, the lymphatics pass down to the celiac lymph node. As we said before, that the esophagus is long structure passing through the neck, chest, and abdomen, so we have different exposure of the esophagus. And this is because the esophagus in the neck is deviated somewhat to the left, so the best approach is to go through the left cervicotomy. While in the chest, the esophagus becomes deviated to the right, so the best approach is to go through right thoracotomy or thoracoscopy. In the abdomen, the esophagus return back to the midline, so laparotomy or laparoscopy are the two approaches for exposure of the abdominal esophagus. This is the end of your recorded session. Please be ready with your questions in the face-to-face session. Your face-to-face session will start with simple questions related to the content of this presentation. I'm expecting all of you to be ready. Thank you.